This is Bob Hartman here. Sorry. As much as I like Zoom meetings, prior to coronavirus, I had been at one Zoom meeting in my life. I think they're about, 5 or 6 a week now, but I always forget to unmute myself. And a little while ago, you may have noted that I blew out. I decided to work from home for this morning, and our home internet connection is not great. So if I blip out, I have to reboot everything, and I'll be back on. You brought up some very interesting points before we get into what Virginia and I talked about yesterday, but you brought up some very interesting points about communications with seniors in Amador County. And we at Public Health and in other organizations have really struggled with that over the years because we are, a diverse rural population. Not everybody has internet connectivity. Certainly not everyone reads the newspaper and the radio station. Now that it's FM, you can get it in most places in the county, but not all. So all these ideas that you've come up with flyers in the food bank, at the senior center, Vanessa Compton's emails that go out every Monday. I think all that's really valuable and worthwhile trying to pursue. In regard to coronavirus, the three websites I think that are the best ones now are the local county, Amador County Public Health website. There's a bar across the top that says COVID-19. You click on that and you can get into latest statistics, but on scrolling on down lower, you can get into press releases, the orders that have gone out from health officer, board of supervisors, so forth. The state, California Department of Public Health website has a significant amount of information. And then of course, CDC has information. This is a novel virus. We're really, I think, still in the infancy stage of what we know about it. And so the science that came out, in March, a lot of it's been proven to be wrong. And there's additional science that comes in every single day. So sometimes it's hard to navigate those websites and to do so, in an efficient manner. But I think we kind of have to do the best that we can. But I really appreciate, and I will bring back to public health, the discussions that you had regarding communication to seniors in this county. It really is a chronic problem. Well, Skip sent out the invite, I think, on Sunday, and I talked with Virginia Manor yesterday, and she asked me just to speak very briefly about coronavirus, particularly coronavirus in the elderly, what we can do about it, and then I think we'll sort of morph into Mr. Tom Dickson, the CEO of Sutter Amador, who is here on the Zoom meeting also. Really appreciate the opportunity to come on board here. And again, I do like the Zoom format. I think we're going to be Zooming a lot into the future. But a concern of ours is certainly that coronavirus seems to affect the older populations more than others. Not in terms of number of cases, but in terms of severity and in terms of fatality rate. Once I hit 65, I started to really take umbrage at the medical articles that would say, the elderly, it's a hypertension in the elderly. And I'd open up the article and look into the details, and it would be 65 and over. And I go, wait a minute, that's not old yet. And this group particularly knows that there are many, many vigorous older Amador County residents. But when you start to look at the statistics in relation to coronavirus, the difficulties, the severity of the disease, and unfortunately the mortality rate, the deaths, tends to go up at about age 60. In Italy, which was hard hit early on with coronavirus, the average age of death was 81 years old. In the United States right now, it's estimated that the mortality rate for those who are over the age of 80 is 15%. Between 70 and 79, it drops down to 8%. And between 60 and 69, it's about 3.5%. And that goes all the way down to, if you're under the age of 20, it's 0.2%. So it certainly affects those of us in the 60 plus age range more frequently. Why? One, there's something called immunosenescence, which means that our immune system gets old. Actually, the immune system probably starts to decrease in function back when we're in our 20s and 30s. And so just our own natural immunity to multiple diseases, multiple germs, viruses, bacteria is decreased. Also, as we get older, we tend to have more comorbidities. And the coronavirus adversely affects those with comorbidities. The biggie is diabetes. The death rate in people who are older who have diabetes is significantly higher. Obesity, and some of the studies have showed that it's a BMI, a body mass index, of between 30 and 40. And that can be easily figured out. Just pull out your phone and Google BMI or body mass index, and you can figure out what your body mass index is. But greater than 30 is considered to be obese. And so that certainly is a risk factor. Heart disease, lung disease, chronic obstructive pulmonary disease, people who are former smokers or who have emphysema have a significantly higher risk of this virus, and predominantly because this is mainly a respiratory virus. That's how it is spread. Droplet spread or aerosol spread gets into your respiratory system, sort of propagates the think in the nose and the posterior pharynx, and then just sort of kind of drops down into the lungs. Granted, there are many complications in other areas of the body where coronavirus affects you, but the death from coronavirus most frequently comes from the pulmonary disease associated with it. Elderly tend to congregate in institutional settings, and that scares the bejesus out of us in institutional settings because, as you're aware, multiple areas throughout the country, in nursing homes, convalescent facilities, assisted living facilities, there has been very quick spread of coronavirus. Other congregate facilities there also has been, such as prisons. We're very fortunate that there have been no inmates at Mule Creek State Prison who have tested positive to date.
Is that right? Wow.
Yeah, no inmates have tested positive at Mule Creek. Certainly in the correction system throughout the state, and San Quentin is being hit very heavily right now. But in the correction system throughout the state, there have been a number of positive inmates, but none locally. And as you probably read or heard, the state is doing early release. And people have asked us quite frequently about that, and the early release of inmates who have 6 months or less in their time in the state correctional institutions and are good players, have not had problems, that are not sex offenders or murderers, so forth. They're releasing 8,000 of those early. We in Amador County, on the early release list, we only have 3 people who will be released into Amador County, and so our probation department will be following them pretty closely. But also to get back to seniors, I could sort of deviate there, sorry. Also, a number of seniors are isolated, don't get adequate information. They don't have adequate support systems many times, and that's hence, the work that the Commission on Aging does. Transportation is difficult. Access to healthcare can be difficult. And then also, and I do bring this up when I talk about coronavirus, I think that there's an element of ageism in coronavirus, because coronavirus mortality affects older people. A lot of younger people don't take it very seriously. There's an element of racism in people's response to coronavirus, because certainly for a number of reasons, mostly health inequities, Latinos and Black Americans are really heavily impacted by coronavirus. I was just reading an article yesterday that the hazard risk for Black American getting coronavirus is 1.53. That means they are 1.53 times more likely to die of it than a white American. And so, there are many reasons for that, but again, it's I say that because I also think that there is an ageist element to it, in that a lot of times, particularly our younger people, don't really interact with folks in nursing homes and in assisted living facilities. And it's kind of like, well, you know, it hasn't bothered anybody in my family, but they're lucky it hasn't bothered, you know, the seniors in their family. So I really worry about that element of it. So, you know, it is a novel virus. We're going to learn a lot more about it, but what positive steps can we take? You know, enough of the negative things. What positive steps can we take? And certainly these are steps that we have heard before, but clearly developing a social system to have people that can check on you, that can help you if you can't get out for groceries or whatever, or, you know, the younger neighbors call up the older neighbors and figure out what they can do in town for them. You got to have a good support system, but also for those of us that are able to get around, exercise outdoors is a key element to keeping ourselves healthy. Adequate sleep. As we get older, we don't sleep as well. The melatonin in our brain just gets all messed up. It's not like the teenager's melatonin, but trying to get good, adequate rest, good, adequate sleep. And don't ignore other health issues. You know, we already mentioned the comorbidities, but you've got to continue to take care of those. And as Mr. Dickson will probably talk about, that means you don't ignore health issues. You don't avoid the emergency department. You don't avoid interactions with your healthcare professionals. I've never liked the term socially distance, because we all have to, we're social creatures. We need to socially interact. So I like to refer to the 6 feet as physical distance. We've got to keep 6 feet away from other people, unfortunately, other those than right in your own immediate household. But the distinction, of course, between physical distance and socially distance is that we all go downhill rapidly if we don't have that social interaction. You know, there's an increased incidence of depression, increased isolation. So we really need to support each other and have good social systems. Masks were mentioned earlier. I believe it was Skip who mentioned that. You know, masks are from what we know about coronavirus, masks are essential. Masks do decrease the spread. They seem to, the cloth masks that we see, seem to decrease more your ability to give the virus to somebody else, but it also does decrease your catching it from someone else. It should be a 2-ply mask. One of the things that just bugs the heck out of me is seeing people wear masks the wrong way. It's down below their nose, or they pop it below their chin, you know, for a while and then back up. Or, you know, I had to go pick up someone at the Sacramento airport, which made me a little bit nervous. And this woman was complying with the airline's mask requirements, but her mask was 2 inches wide. You know, and it just really didn't cover much of anything. But she said, "I've got the mask on," and was heading towards the airplane. But particularly, you know, the virus doesn't move. We move, and when we get out and about, there's the potential for us spreading the virus, and certainly potential for us catching the virus. So if you're out and about, you know, you've got to be wearing your masks. I think we also can, you know, we can walk with our feet. If we go into a business and the employees do not have masks on, or a substantial number of people in the store don't have masks, and no one in the store is doing anything to try to request that they wear masks or to make masks available, we can walk with our feet in our wallet, just not go to those places. And I've done that several times here in Amador County. There's you know, I changed my pharmaceutical where I get my drugs because of that. So we can have, you know, we can have an impact. One, by example, by wearing masks, staying physically distant, staying home except for essential activities, and all. Hey, great mask over there on Skip's.
Jeannie.
Thank you. That is worn the right way. You get a
And
gold,
it came all the way from the San Blas
gold star
Island.
today. Oh, also, I would like to, there's a group, there was an article in the paper last week, I believe it was about Christine Cox, but then Pearlie Tyson is one of our neighbors up here in Pine Grove. And Pearlie has gotten together with Christine and about 4 other seamstresses in the county. And they have made masks for distribution to homeless, adult protective, child protective services, behavioral health, some to vineyard workers. And to date, I keep running track of this because I help to distribute them. And to date, for that particular group that come through the County Emergency Operations Center, they have made 1,771 masks. And I think it's just incredible that they do that. And so if anyone on this call has any problems getting masks, you could, just shoot me a message, and Virginia knows how to get in touch with me, as do others on here. And we can make some arrangements. I know Mr. Brown said that some people up country are having a difficult time getting masks, and we have given them to some of the facilities up there. Through the Emergency Operations Center, we can give to healthcare entities and other kind of congregate living areas. We can deliver, we can get masks that come from either state supplies or federal emergency management supplies. For instance, yesterday I delivered to one of the dental offices 60 N95 masks that healthcare workers who have close contact should be wearing. But as one fellow who helps us distribute masks to the homeless said, there are many reasons and many controversies around masks, and people will give you various reasons why they don't wear masks, but not having access to a mask should not be a reason. And quite frankly, other than a very limited number of people who have medical reasons why they should not wear masks, there are very few people. Under the age of 2, yes, some kids between 2 and 10, difficult, some chronic medical conditions, but they're really not very many. So we should be seeing near universal mask use. CDC yesterday said that if we all use masks, that we could start to curb this within 6 weeks. So anyway, I'm gonna be quiet. I really appreciate this opportunity, and I know Mr. Dickson's on the line, and he and I have talked in numerous locales about sort of the interaction of the public health and the medical community, the hospital community. And so Skip, can I use this as introducing Mr. Dickson at this point?
Absolutely, please.
Okay, Mr. Tom Dickson is the CEO of Sutter Amador Hospital, started, I believe, in February of 2019. And the transition from the previous CEO to Mr. Dickson has just been really seamless. He cares about our community, cares about our hospital, he cares about the staff and the quality of care here in Amador County. And he and I have been on many panels together, many discussions on the radio together. And I'm proud to have him be a healthcare colleague in our community. Are you still there, Tom? You're muted, Tom. You need to.
Wait, I'm muted. You're right. Sorry.
How do you unmute yourself?
It's always a challenge on Zoom. I never know when I'm muted and not. So, hey, but thank you for that. I heard that introduction, so thank you, Bob. And I want to thank you for the opportunity to come talk to you. And I would assume that what you're going to want to know, but please let's get me on track if I'm not on the right track. Is just what are we doing at the hospital? What are things like? Current status? Maybe any kind of projections for the future? Is that what you're looking for?
Yes.
Okay. Yes. So maybe 10, 15 minutes, and then open it up for questions. Is that?
Yeah.
Is that
thank you.
Okay. Good. All right. Well, so I just wanted to start by saying that I received an amazing orientation to this job from Ann. And she said, you're going to get invitations from organizations like yours. And she said, please take them up on it. It's a valuable connection. And so I'm talking to Ann less and less as she's really kind of enjoying retirement more and more, I think. And so, but I still do keep in touch with her. And so this is my first opportunity, though, as you know, to speak to your group. So let me, just to kind of put it into context, I would like to maybe just briefly start with what was the starting point for COVID-19. And so, just real briefly, so China tells the World Health Organization about this new infection January of this year. China recorded their first death from coronavirus January 11th. And then the first reported case of coronavirus in the United States was reported January 20th. So, I mean, this is all stuff that has really started this year, and it has literally transformed the healthcare organizations and the public health organizations and community organizations of various types. It has had an amazing and dramatic impact on healthcare and concern that people have about public health. You may not know that all hospitals in the United States, I believe, really kind of respond to emergencies in the same way. They create an incident command, and they're using the same format, the same terminology and nomenclature, very similar to what's going on at the county. They have formed an incident command, and it is an alternative structure for the control and kind of distribution of resources to deal with a crisis. So we would, when we had the fire outages last year, we had the power outages because of the fire. We created incident command. When there were fires in the community years ago, we created incident command. And so, as you would expect, that's happened. So we started up our incident command in March, and before that, Sutter Health kind of created its own overall incident command, actually as early as January 24th. So they pulled together a group of individuals. They staff it 24/7. They provide direction, and we provide information to them. They provide direction to us. And so that system of incident command has been in place since really the end of January, and all 25 hospitals of the Sutter Health system have their incident commands in structure, and that's how we kind of communicate with each other about what our response is gonna be. The other thing that you probably know is there are many different organizations that provide guidance to hospitals, whether it's the CDC in Atlanta or whether it is the CDPH out of Sacramento, public health, whether it's the county, OSHA gets involved periodically, and there are many different organizations. And so we take our guidance from a lot of different organizations. And so I wanted to just kind of talk about the things that we have put in place to try to protect our patients and our staff from a novel virus that no one in the United States has much experience from. So you probably all know this is easily the least popular thing that we have ever done in this organization, but we restricted access to visitors starting March 17th. To my knowledge, most, if not all, hospitals in the United States did it early on. There have been some organizations that kind of loosened that restriction, but and the restriction I'm talking about is when visitors come, unless there is there's only a few extenuating circumstances, but for the most case we say visitors are not allowed. And again, there are 3 or 4 different examples of exceptions, like end of life care and things of that nature, birth partners. But that was an attempt to try to make sure that we get the utmost control over having the infection actually in the walls, inside the walls of the hospital, because it could easily spread. And so that happened March 17th. We had sort of a mini surge in the middle of March. A number of patients showed up into the emergency department suspecting that they may have had coronavirus. We had our admissions were growing up, and so we suspended elective surgeries March 18th. That was an attempt to try to free up the staff and free up the space that we needed to take care of a more than normal number of patients. But we did away with that, of course. We ended that May 4th. And once we saw the curve it looked like the curve of the incidence of COVID-19 was starting to flatten out. And so the other things that we've put in place through our incident command structure are universal masking for all employees, universal masking for patients. We've done we put the screening process in place, so no one gets into this hospital without being screened for temperature, and we ask them questions about whether or not they've had the symptoms that might lead people to believe that they were going to be having or might have the virus. And so again, but you know, those are things that we did, and those things are still in place. What's our current state? Our current state is we've resumed full surgery schedule. Our emergency department volume has returned to back to normal. In fact, we are far exceeding our normal levels now. You probably heard, or you may know, that during the height of COVID-19, a lot of people just decided to stay away from the hospital, stay away from the emergency department. We had a number of examples of patients who really clearly needed care. Either it was, you know, symptoms of a stroke or other serious conditions. They decided that they were going to wait it out because they were afraid that if they came here, they would be at risk for getting COVID-19. And sometimes that can have disastrous consequences for patients. And so that seems to not be the case anymore. Again, our emergency department is seeing very, very high volume levels. So the other thing that I will tell you that we've done, because, you know, we're paying close attention to the environment around us. You know, to our west, Stockton and Lodi, and of course San Francisco and LA, the hospitals are really having a difficult time keeping up with the demand for services, right? I mean, whether it's critical care services or just, you know, people coming in wanting to get tested. So we suspect that is going to migrate. In fact, it has begun to migrate in our direction, and we think that it is possible that we are just seeing the beginning of a surge for services here at Sutter Amador Hospital. We hope not, but it certainly looks like it is. So we may have to institute more measures in the future to really focus on the patients that have the most acute need for services, like temporarily suspending elective surgeries again, doing away with some of our elective procedures. Like, you know, what we did before was we terminated the pulmonary function laboratory testing services, we terminated the sleep lab, we did away with some of the other diagnostic services, again, just so we could focus the resources that we have on the patient need. And so those are all things that are possible. We certainly hope not. We hope that we could maintain the volume of patients requiring acute care services or testing services at about what they are. The other hospitals to the west of us, and certainly, you know, New York and Texas and Arizona and Florida and other areas. The other thing that is going to be a very difficult situation for us to deal with, if it happens, is if our employees have symptoms, right? Then we have to test our employees. They have to be out for 2 weeks. And so the volume, that is probably the scariest side of what it is that we may have to deal with in the future, that we may have space, we may have rooms, we may have equipment, but if we don't have staff or access to the highly qualified staff that we would normally have, that will be a big problem to overcome. I would like to maybe just kind of finish on this thought though, and then I'll take your questions, or Bob and I can take the questions on a combined basis, is, you know, we're part of a healthcare system, right? We're part of Sutter Health, and we have access to the resources of Sutter Health, and we intend to use them. In fact, in our surge plan that we put together, and we submitted the surge plan to the county and to the Sutter Health Incident Command, it is, you know, if we need to transfer a patient needing critical care services because we're at capacity, it's already been designated that the Sacramento facility is the facility that we'll use for that purposes. If we need equipment, there is sort of a central number where we can call and request equipment. We can call and request staff if we need it. And so we fully intend to utilize the resources available to us throughout the Sutter Health system That's really the way the system is designed to operate. And so we are, you know, we're anticipating the worst case scenario, and we're planning for that, but we're hoping for the best. And I think that's going to be kind of one of the things that guides us through this process. Is it could get way worse. We have various ideas on how to take care of it, but we're certainly hoping that we never get to that. Are there any questions that you would want maybe Dr. Hartman or I to focus on?
Well, I'll ask one. What is your capacity for regular beds and the ICU beds here?
Well, we're licensed, excuse me. We are licensed for 52 beds. But of course, you know, every one of our beds is licensed for a particular purpose, right? We have 6 critical care beds. We have the ability to take care of, additionally, 6 progressive care beds. So progressive care is a step down from critical care. We have a certain number of beds reserved for OB, and those really can only be used for OB. We've got a certain number of beds that are med-surg. We've got 14 beds in the emergency department. And then we have really in our surge plan designated alternative sites where we would create we would create, with the state's blessing, critical care services or progressive care services in other locations. We would have to notify the state that we were doing this, and as long as we have the equipment and we can meet the regulations and the staff, the state is fine with us doing that. And that is not normally true. Normally that would only be authorized by the state in situations like this, in an emergency situation. Normally you are prohibited from doing something like that. But so we're grateful that we have the flexibility to borrow resources and create temporary spaces like tents outside the emergency department. That would not normally be allowed by the state or any other licensing organization, but we have all of those measures in place now and plans in the future for alternative sites.
So if someone was critical enough to need the ventilator, would they have to be sent up to Sacramento?
Well, our surge plan works like this. So as soon as we hit 6, so if we have 6 patients on ventilators in our critical care unit, so we are at capacity, then the surge plan would say the next step is we call Sacramento. We say, do you have room? Do you have space? They have a large number of patients there. It's a very large organization though. So today they would be able to accept any of our transfers. If the answer is no, then we begin to take our PCU, our progressive care unit, and we begin to convert that to a critical care unit. So as long as we have the staff and the ventilators and everything we need, that's how we would handle that.
Okay, so you refer to it as critical care, not ICU. I guess that's a
same
phraseology that we've all picked up.
Yeah, no, it's the same thing. You're right. Critical care, intensive care, surgical intensive care, those were all just different names, but it's the same level of care.
Great, thank you.
And Tom, to date, how many people have been hospitalized for COVID, and what were the ages?
So let me throw out another little acronym for you. So PUIs, right? So a PUI is a person under investigation. So there are people that come to our emergency department, and they've got the symptoms of COVID-19, and so but they're also, we're concerned about many people that come with a symptom and a test. We just send them home, and we say we've got the test. We will call you as soon as So go home and isolate yourself. Be careful that you don't leave your home. And we'll call you with the results. So there are a lot of people that were in that category, hundreds of people that were in that category. Some people needed to be admitted for like a day or two because we were just concerned enough about them that we wanted to keep our eye on them. I would say we probably had a couple dozen patients like that. We've had 2 patients, I believe, that were sick enough to be admitted and cared for in the critical care unit. So very small number, but that's been increasing. We've had more and more people come to the hospital lately with symptoms of COVID. We test them and we have to admit them. So that's one of the areas that we're concerned about, because we're seeing that increasing pretty dramatically.
But in the other cases, they were able to be treated and sent home.
Treated and
If
discharged,
they
yes.
were COVID positive, but actually hospitalized on the prepared wing. That was 2 positives.
Two people in critical care. And one, unfortunately, passed away just recently.
Right.
60-year-old woman.
San Joaquin County, correct?
Right.
I have a question.
Yes.
Could you clarify the availability of testing? The adult son of a friend was seeking tests, and there seemed to be, he was told that he had to go through a certain place online to find a place to get tested, and was told that the hospital, Sutter Amador, was not able to give tests. This is just within the last few days.
Right. So let me just kind of start this, but I think this is where Dr. Hartman can help a lot too. So first off, you just need to know, we have been able to do COVID testing since almost the very beginning. We're an acute care hospital though, so we try to really focus on people that have symptoms and people that really have, so that is
Right.
available, that's been available. Now, if the individual you're talking about didn't have symptoms.
He
then,
does.
Oh, he does have symptoms. Okay, so he could have come here with symptoms. He would be evaluated by a nurse, evaluated by a physician, and they would make a decision as to whether those symptoms were suggestive enough to warrant a COVID-19 test. But let me just kind of turn this over to Bob, because I would say the one thing that I wish we had much more of, and a much better system and more availability, is testing. Testing is, in my opinion, even though we've got four different sites to get tests in this community, this is the biggest problem in my opinion. But Bob, do you want to talk about testing?
Yep. Thanks, Tom. You did. I am unmuted. Good. You did mention that there are 4 sites in Amador County to get tested. And certainly Sutter Amador Emergency Department has done a significant number of tests. And as you said, if you show up to the emergency room and your symptoms are compatible with COVID, and there's a low threshold for that. It's not like you've got to meet all 10 symptoms or anything. Low threshold. You can be tested. All inpatients are tested. All pre-labor patients are tested, and multiple pre-surgery patients are tested. We have tried to move the pre-surgery testing outside of the emergency department. And so Sutter is set up over on Court Street, a testing center that's open Monday through Friday in the afternoon that Sutter medical clinicians can refer to, primarily for patients who need pre-surgery testing and people who need like a return to work test. It's for asymptomatic patients only. Of course, the emergency room is for symptomatic patients. There are 2 other testing sites. WellSpace, the federally qualified healthcare center in Martell, has a separate entrance that is called their COVID screening clinic. And you do not need an appointment for that. I believe the hours are 8 a.m. to 6 p.m. Monday through Friday. And they will evaluate you. And if you meet the criteria to be tested, they will do a test that day. The 4th place, and the one that has the largest volume of people coming through for testing, is called the Verily site. And that is a testing site that can be considered for people who have only mild symptoms or people who might have been exposed, people who are in high-risk groups, and people who just simply want to know, do I have coronavirus? It's a drive-through site, and this may be what you were referring to, Mr. Denney. The only way you can be seen there is if you have an appointment ahead of time. You go to a website called projectbaseline.com. I will say it is not a simple sign up. You have to have a Google Mail, and then they give you the California sites, and you check Jackson, and then they'll give you the available times. They only open up the available appointment slots 1 week in advance. And so we have been filling up for the last like 3 weeks. We fill up right away. Again, that's projectbaseline.com is where you go for that. It is a drive-through site in the parking lot behind St. Catherine Drexel. They have been absolutely wonderful. Their staff has been great about letting us set up out there. We're either 2.5 days a week or 3.5 days a week there. It is free. It does not cost the consumer, the patient, anything. It is supported by the state, and the public health department here locally gives a lot of the support regarding setup and breakdown and staffing, so forth. Right now, that site is doing the most testing in the county. It varies week to week, but probably between 400 and 600 tests per week are done there. We certainly have had some positive tests come back through there. And the bugaboo with all of this is the turnaround time. We talk about the TAT, the turnaround time. There are so many tests being done in the state. Like yesterday, I think the number of tests done in California was 134,000. So the lab capacity, while it has increased from March, 1st of April, I think it was, we were doing 2,000 tests a day in California. Now, we're over 130,000 tests a day. So it takes a while to get them back. And the state has come out with guidelines about who gets first in line on the testing. It doesn't mean that places like Verily are going to close down. What it means is it's going to take longer to get your test results back. Early on, it was 3 to 5 days, then it went 5 to 6 days, and now it's usually about a week before you get those results back. Compare that to Sutter Amador Hospital. If you're eligible for rapid testing at Sutter Amador, the test result comes back in less than 2 hours. If you go through the regular Sutter shared labs, the test result comes back in 24 to 48 hours. But the labs like Quest and LabCorp and the myriad of other laboratories in California that do the testing are just so backlogged. It takes a long time to come back, and that kind of hampers our contact tracing, which we do for every single positive case in Amador County. A lot of our work at Public Health Department has been this contact tracing. To date, we have 45 positives in Amador County, so every single one of those had contact tracing. But a lot of the contact tracing is actually done in people who are positive in the surrounding counties. And they either worked in Amador County or had contact exposure in Amador County. They, came in and went to a birthday party in Amador County. And so we have to do that contact tracing. Never counts in our numbers. The numbers of residents in Amador County. Also, because the testing sites in California have been impacted so heavily, people will go online, and you can go to the CDPH, the California Department of Public Health website, and it'll be where can I get tested. Amador County has where can I get tested, and it kind of shows you the regional, the Amador County ones and the regional ones. But because all of those places have been so impacted, we are seeing a significant percentage of people tested at St. Catherine Drexel from out of county. Initially it was like 5%, and we don't have a good grasp on the percentage, but we're estimating it's gone up to about 25 to 30% of the people who come there actually drive to Martell from surrounding counties so that they can get tested because their testing sites in county are so crowded. Anyway,
Yes.
Sorry, long-winded way of talking about the testing.
No. Can you once again tell the how does someone find the second online source?
The site at St. Catherine Drexel is projectbaseline.com.
I got that one.
Okay. The second one, what you can do is go to the Amador County Public Health website and go to the COVID page, and you have to scroll down on it, and there is a section there that says, where can I get tested? You click on that, and it gives you not only the Amador County testing sites, but those that are in the region. For instance, there's a large testing site down at the fairgrounds at Angels Camp. Kirkwood has, it's either one day a week or one day every other week. And I happened to be up at Kirkwood last Thursday. They were doing testing there, and they had 160 people scheduled at Kirkwood. Again, because people from Nevada can't get tested, would drive over. Other people would see you. Kirkwood, great, I'm gonna go up and go for a hike and then go get tested. So all of them have been impacted, but those are probably the two best places to go. The California Department of Public Health does have a map on their website that shows where all the testing things are. It's interesting that if you look at it, Amador County, until we got a little bit more robust in terms of testing, was what was called a testing desert. And the state testing task force realized that, and that's why we were able to set up the St. Catherine Drexel site. But if you look at that map and you look along the I-5 corridor, the 99 corridor, the 50 corridor, fair number of testing sites. But then you start to look in rural areas, Amador County, Calaveras County, the foothills, the eastern slope, not very many testing sites. So the state's trying to rectify that, and they're still working on sort of equality.
What was the criteria?
Thank you for that information.
What was the criteria for the second Sutter site on Court Street? Could you repeat that one, Bob?
And maybe Tom can help fill in here.
Oh.
It is available only to Sutter clinicians. So it has to be ordered by a Sutter physician, nurse practitioner, PA. Doesn't mean it's restricted to Amador County. For instance, they have had, there've been like a neurosurgeon wanted his patient to have, before got a particular MRI, wanted his patient to be tested. So he put an order in, and that person could get scheduled at that clinic. Unfortunately, I don't have the phone number right in front of me, but it is primarily for pre-surgical, pre-procedural, going back to work, because some places require you to have a test before you go back to work, and the person has to be asymptomatic, and they're open it's either 2 to 2.5 hours Monday through Friday in the afternoons. I can find the number and get it to Skip or something. But it is restricted in what they can do.
Right.
And that's by appointment only too, right, Bob?
Yeah, correct. That's right, Tom. It is appointment only. Yeah.
Right. Got it. Thank you.
Are there any other questions from anybody?
I have one. I just heard about this. It says that people who wear their masks too much can get hypoxia. What's hypoxia? Don't need to worry about that?
I'm sorry, your question kind of skipped out there. I just heard the hypoxia right at the end. Well, hypoxia means a low blood oxygen. And
Ooh.
so particularly since this is a respiratory disease, and it can involve the lungs pretty extensively in moderately and seriously ill people, you don't get oxygen exchange good enough. So people get a low oxygen level. Interestingly, rarely, that can be the first sign that some people have, is kind of a shortness of breath, and then you check their oxygen level. We're okay if we're 92% or higher, but you could have someone get short of breath or oxygen levels in the mid 80s, and bam, very shortly thereafter, the full spectrum of coronavirus symptoms come on.
Bob, the question though was,
I'm sorry.
Getting hypoxia as a symptom of wearing masks.
Oh, I'm sorry. I missed that part. There were some studies done back before coronavirus that suggested that some people with respiratory symptoms, with chronic obstructive pulmonary disease, with emphysema, could get short of breath, and get hypoxic by wearing a mask. I'm sorry, my Zoom bleeped out a good portion of that. So the overwhelming majority of people do not get hypoxic. I actually exercise a lot at work. So one day I decided to wear my 2-ply cloth mask while running, and I did get more short of breath than usual, but the studies have shown that the incidence of getting hypoxic with the mask is really very, very low. So if someone does feel significantly short of breath with a mask, I would suggest that they get a different kind of masks. You still can get some of the procedural masks. We urge people to wear cloth masks because we like to save procedural masks, which are also called surgical masks, for our healthcare workers. But frequently, those are lighter, even though they've got very good, very good efficacy. They're lighter and they're easier for some people to breathe through.
Thank you.
Now, my question is for Dr. Hartman also. I've heard through the research that zinc is very effective to take, as well as vitamin D, being outdoors, taking a walk, being in the sunshine. That the coronavirus doesn't, in fact, it kills it, the vitamin C, the vitamin D. Sunlight.
That Virginia, that's a very good question. Supplements in general don't tend to do much in regard to coronavirus. Lots of people take multiple supplements, and I think most of them they're urinating or defecating it out of their systems, and it doesn't do a lot. That said, there is some evidence that regular vitamin D does help to keep people healthier, or if they get coronavirus, the symptoms are lessened. Zinc, the studies are less emphatic, or less tending towards that. So I think school is still out on zinc. Vitamin D may be good. I think, again, getting back to what can we do, we can exercise, we can eat the right way, get plenty of sleep. But you're right, Virginia, about vitamin D. It does seem to have some beneficial effect.
And sunlight.
Yeah, but it can also be supplemental vitamin D. Certainly
yes.
we get vitamin D with sunlight. But the interesting thing, since we're on the Commission on Aging, one of the interesting things is that the way that vitamin D gets converted, or the way that sunlight kind of activates and gets vitamin precursors converted to vitamin D in the skin, in a lot of people decreases as we get older. So you need to, it's not a, if you're going to take a supplement, I think a vitamin D supplement ought to be, I don't agree with people taking, 46 different things a day, but vitamin D should be somewhere up near the top. Number of women on the phone call, calcium should be somewhere up near the top, not because it has anything to do with coronavirus, but it's good for our bones, particularly as we get older. And the combination of vitamin D and calcium is great for our bones. That would be interesting sometime, Virginia, to sit down and say, take 50 supplements and have healthcare personnel sort of sit down at a round table and rank them as to what they would take and what falls way to the bottom of the list.
Yes, truly. Thank you, Bob.
Yeah, are there any other questions?
Ask him about kids.
I don't have a question, but I have an offer, and that is public access in Calaveras has Dr. Kaleda coming in once a week to do an update. And if you doctors would like to go to public access TV in San Andreas once a month, or once a week, actually, he's doing it once a week. If you want to set that up, it's available to you. Our programming goes out to Volcano Vision, so I know that it hits Ione and Pine Grove pretty well, possibly Pioneer. Anyway, so if you guys want to take advantage of that, we also put all the programs up on our YouTube channel so they can be shared via the internet. And the number is 209-754-5666. 4021. You can just call Ed Lark and he can arrange to set you up.
Thank you so much for that. As yesterday, I received a email link to Dr. Kaleda's latest video there on the public access in Calaveras. And I think, early on, you were talking about dissemination of information to seniors, and I think we just need to be as cognizant as we can that people really need a fair amount of information or a lot of information, and the more that we can do to get correct information out there, as Mr. Denney said, scientific information out there.
Absolutely.
I do have a question to go back for a second to testing for Dr. Hartman. And that
Certainly.
is,
and hi, Tanya. Good to see you.
hi, good to see you. The testing is sort of vague to me, and that is, why are people going to Catherine Drexel to be tested? I just have to be a little bit more clear on that, because if you have no symptoms, and I know it's great to know if you're asymptomatic, but you're only then tested for that one moment in time, and 3 days later you can have the coronavirus. So when should we be advocating the testing?
You're absolutely right, Tanya. That the PCR testing, the nasal swab, and I should say, just to back up a little bit, at Catherine Drexel, it's a self-collected nasal swab. There are two healthcare workers. They instruct you on how to do it. And it's not the nasopharyngeal that early on was being used, where, as people described it, as tickle your brain by sticking this thing up your nose. It's not that anymore. It's what we call mid-turbinate. It only goes in an inch at the most. And then you swirl it around, so it's a lot easier to collect. I have had to show some of the healthcare workers how to do it, so I've done that self-collecting and throw the swab away on myself numerous times. It makes you sneeze, and it just kind of irritates your nose. But you raise a very important question, and that's why the state has said that it's worthwhile to sort of prioritize the testing in those asymptomatic people that are, number one, curious about it. Number two, don't want to be spreading it in the community, because probably 40% of people who get coronavirus are asymptomatic, don't have any symptoms. So it would be good if we could save our testing for those symptomatic people or high risk people. However, and the state of California and other places recognize this, it's important to know what the community transmission is and the testing positivity rate is in a given community. You might have read that in Florida, there have been some places that have had 14%, 19% of their tests positive. That can give you an indication of what's really happening in your community. Amador County over the last several weeks has been between 2.2 and 2.6% testing positivity rate, which is really low. The state has said that if you're at 8% or higher, you're in trouble, and they're going to put you on a watch list to really see how you are mitigating against spread of coronavirus. So it is helpful there. You're right that it is a point in time, and I could test positive today and 3 days later, other way around, test negative 3 days later, test positive. But we still do get information. We still do contact trace those people who are positive, and we still do ask them to isolate themselves so that they are not spreading. So there is some value in it. Some people have used it for things that are a bit questionable, like we've had folks come through and say, I want to be able to go see my grandkids this weekend, and so I want to make sure I'm negative. But again, just like Tonya pointed out, you might be negative on Wednesday and positive on Saturday, and it's better to stay within your own household that you've been sheltered in place with. So that's a wide-ranging answer that there are some benefits to it, but it's also why the asymptomatic people have been pushed to the back of the line. If we're doing 130,000 tests a day, we don't want not test those people that really need it in real time or as quickly as we can.
And now, I was just going
I'm
to say, now the research also is coming out about the
Yeah,
antibodies.
how does he feel about kids going back to school?
Yeah, antibody testing is, as Dr. Rita Kerr, the health officer, described, is still the wild, wild west. We're not quite sure how to take antibody testing. I can remember back 1st of April saying, hey, and we'll have antibody testing in a couple of weeks and we'll know what to do. It'll help us a lot. It does not help us a lot at this point because we don't know how much immunity it confers. We think it does confer some immunity. We also are, well, I think the main ways to use antibody testing at this point are if you've known you've had coronavirus, you've been positive for coronavirus, and you want to donate your plasma. I think that's a very, very valid reason for doing testing, because some of the research shows that if you're really moderately or severely ill and you get plasma, in other words, getting the antibodies from somebody who's had coronavirus, that it can help save your life, or certainly decrease the severity of the disease. The other thing is that we're going to be using, I think, more serology in the future, is really trying to figure out how many people have been infected, where it is, what it's done in our communities. And you look at little kids. One of the theories why kids under the age of 5 get coronavirus way less than adults is that there are circulating coronaviruses that are not this novel coronavirus. But in kids, a lot of the common cold is a coronavirus, and so adults, sometimes a common cold is coronavirus. And so the thought is that maybe they're getting a little bit of immunity, cross-reactivity immunity, and so it doesn't strike the kids as much. Also has to do with some weird receptors in the nose that are that the relationship in adults and kids is different, and so maybe that is, it's called angiotensin receptors, and so maybe that has something to do with it. But it's that whole immunity area is fascinating, and we just don't know much about it right now.
But
Well,
that's
I had tried this.
speculative, right?
I'm sorry?
That's speculative about the young children.
It is speculative, absolutely. And I'm going to have to say, Mr. Denney, that while the science is the reams of science coming out every day, those of us in the medical community will get 20 peer-reviewed articles about coronavirus daily. We don't even have time to read them. And the stuff we're learning is coming out so quickly, but that kids' protectiveness is speculative. The whether antibodies really do protect you is speculative.
Well, then maybe I can ask.
Some of us hitting in here. Dr. Bob, one of the reasons why I asked that is because this week I had contacted my doctor to have an antibody test done since back in January. Last time I saw you, matter of fact, when you popped your head in the door, I ended up with double pneumonia in the hospital for about a week. So all my family have thought I had COVID, which would have been early for this country, but who knows. And I was told, and I just read an article online before I even contacted the doc, that now they're suspicioning that antibodies, or they're finding out, drop off. They can drop off as early as 3 weeks after COVID or after 3 months. And so he sort of thought it was a moot point for me to go ahead and do antibody tests. So that's one of the reasons why I asked you. So you're right. There's so much coming out that it's just, I don't know how you guys can keep it all in place.
Tonya, we've heard from multiple people in Amador and surrounding counties that they had a significant illness December, January, February. And then when coronavirus information came out, a lot of them said, I must have had coronavirus. We have had, there have been, we receive some information about the coronavirus antibody tests in the serology. And I think to date, of the 130 or so people who've said that, we've had 2 positives, serology. So there was something really nasty going around in the winter, but so far it doesn't look like it was coronavirus.
Yeah.
But you're right. They some antibodies you get measles, and antibodies stay around for years and years and years, and other antibodies just drift away really quickly.
Yeah. Well, certainly this next year or two is going to be a lot of learning for everybody.
It will be, and then, you know, vaccines at some point. You know, will it be by the end of the year? I don't think so. Will we have vaccines in a year? I think we will. But I think it's going to be, you know, school is still out on the vaccines also. Now, personally, will I get a coronavirus vaccine? Yes, I'll get one as soon as it's available after it's gone through the FDA approval. I will, you know, because I am a firm believer in vaccines. I think they've saved millions and millions of lives in the United States, you know, over the last century plus. And the downside of vaccines is really pretty minimal. There are, you know, you can always bring up the old flu or the, what was it, the swine flu back in the 70s, you know, and there were a fair number of side effects from that vaccine. But I think that this coronavirus is, you know, we're still early on, and it's got a potential to just keep going on and on. I was on a fascinating Zoom over the weekend with a World War I historian who has taught for decades at the United States military, the War College. And he has studied the history of World War I. And in the chat, things that we could send back to him, I said, what made the 1918 pandemic go away? And it fizzled out, but over several years. And it really took physical distancing and masks, you know, kind of finally made it go away.
Yeah.
But, you know, so we don't know yet. So I've got to shove off and get to another meeting here. This has been fascinating. Thank you. I'm sorry, one more question.
One more question. How do you feel about kids going back to school?
Wow, that's a loaded question.
Yeah.
That's a loaded question. I think kids going back, yeah, you know, the socialization, the interaction of kids with each other,
Mental health,
kids with
yeah.
teachers is so incredibly important. At this point in time, I don't think that we have a good way that we can protect our kids and protect who's more vulnerable. You know, it's their teachers. Their teachers' aides, the people who work in the cafeteria, you know, the administration. They're way more vulnerable than the kids. You look at pediatric studies, and the kids really don't spread it that much. But and they tend not to get as sick. But it's certainly something that we need to be really careful about. I think wholesale opening of schools, as we were, you know, 10 months ago, should not happen. I think we need to be extremely careful about how it is done. That said, probably every other day we're on some kind of health officers conference call or California Department of Education conference call with people people way smarter than us, you know, kicking these ideas around. So I do think that there would probably be some combination of distance learning plus pretty significant modifications in school. You know, I mean, some school districts have proposed, let's have in school, you know, 1 day a week, larger classrooms, fewer students, 6 feet apart, you know, hand washing stations, masks if the kids can wear them, and that's 1 day a week and everything else be distance. And then, you know, that may work. And Zoom chat rooms and stuff need to be incorporated as much as possible. As you all know, the resources necessary for that are going to be significant. You know, not all families have the ability to get their kid an iPad, you know, so that they can do distance learning. So we have to look at the equity issues in the schools also. You know, we could get a lot of questions about colleges too. If I were in college or I had kids in college, I would not want them going back and living in a dorm and, you know, in an environment with other 18, 19, 20-year-olds. You know, it's just, it's a little too scary right now.
My grandson's on his way.
Yeah,
Well, thank you.
I'm gonna have to leave too.
Both. We really appreciate you coming on today. You're a wealth of information, and certainly you've gone longer and taken more time, your valuable time with us, but we really appreciate that information.
Yeah, thanks for having us on. You know,
Thank
discussion is always good.
Thanks for the
you.
invitation.
Thank
Thank you very much.